We're going to needle the gluteus medius muscle, and this is a hip stabilizer, but it can create pain through formation of trigger points, particularly in an individual who has some form of hip pathology. So where they are standing on one leg persistently and their hip stability is failing, so they have a positive Trendelenburg test, the gluteus medius can become overactive, and in many instances it can become less active and it can fail eccentrically. So we're going to isolate the muscle itself, so we find the muscle by locating the iliac crest, and we come down by 3 finger widths. Now, we're in a small triangle with the iliac crest here, the greater trochanter here, and our inguinal structures here. So we're maintaining our position within this triangle. We confirm the muscle location by a manual muscle test. So if you could just press your knee upwards against my hand, that's fine, and then we come down again. So if the patient is in pain, we're trying to reproduce their familiar symptoms. So if I press firmly onto the skin, that's going to hurt anyway, but does it reproduce what he is complaining of? So he may find that he gets hip pain, for example, when he's running. So does it reproduce what he's feeling? Okay, so we start off using some hand sanitizing gel on the hands and on the patient's skin. Now you notice that I'm wearing a glove but only on one hand, and this is because with dry needling we're often using manual therapy as well. So the advantage of using a glove is that it protects my skin and to an extent it protects the patient, but the disadvantage is it's difficult to feel the very fine needle with a gloved hand. So what we do is we insert the needle with a non-gloved hand, and we keep the gloved hand in case we need to palpate around that skin area. And as we insert the needle, we make sure that the hand, our inserting hand, only ever touches the needle handle. So it doesn't touch the part of the needle shaft, which goes into the patient. So I've taken the wrapping away from the needle and I'm holding the needle horizontally so that the needle can't fall. I've located the area and I'm going to palpate to see if I can find a tender area or a trigger point. So I'd be looking for either a taut band of the trigger point or a small nodular area. Having located that, I place the needle onto the skin, protected by the tube, tap the needle to the required distance, that breaks through the skin rapidly. As I withdraw the tube, the needle then stands up, and I can manipulate the needle gently using my fingers onto the handle. So I'm looking at a change in selective tissue tension, so I want to see if I can feel a gripping to the needle itself, if I can reproduce his symptoms. So he may say that he's feeling the symptoms moving away from the leg, for example. As I come to withdraw that needle, as I lift the needle up, it's going to drag with it a little bit of skin. So I'm going to push the skin down, but not with my own fingers. I'm using the tube of the needle to press the skin down so that I'm keeping my hands away from the needle as it comes out. Needle goes into the sharps bin, and then the tube just goes into the general waste bin. Once we've done this, we're going to inspect the area, make sure there are no spots of blood. If there are spots of blood, then I'm not going to compress that area with my finger. I'm going to use a sterile cotton wool ball just to give a normal compression until the bleeding stops, until we establish hemostasis. And then if we've got a spot of blood on there, that goes into the yellow bin or into our clinical waste bin. For our next muscle, we're going to move over onto the gluteus maximus. So if you could just pop yourself onto your front, and just move that so there's not problems there. Okay. So we've got various different methods of palpation and of methods of isolating the trigger point. I need to think about the structures under the skin where I'm going to needle. So I know that coming down here, I've got the spinal cord and it shoots off as nerve roots. Those nerve roots come together to form the sciatic nerve, which passes through the buttock and into the leg. And I know that the sciatic nerve exits the buttock between the greater trochanter and the ischial tuberosity. So any needle that I'm using wants to avoid this area where the nerve becomes more superficial. As I come to the center, I've got the sacrum here, and we've got our sacral nerve roots moving out. So I need to avoid deep needling into the center of this muscle. So we've got our gluteus maximus. Beneath it we have our piriformis. So we're going to avoid needling deep here. We can needle and angle outwards towards the trochanter, or we can needle and we can angle inwards towards the sacrum, but we're going to avoid deep needling in the center. So I can isolate the muscle either using flat palpation, so pressing the muscle down to create a more taut drum, or I can isolate by using a fold, and I don't just want a skin fold, I want an actual fold of the muscle to draw the muscle upwards. Now both techniques have advantages and disadvantages. They isolate and they get me to be able to control the area, but obviously if I'm using flat palpation, I'm pressing down towards the structures beneath. So if I want to avoid the sciatic nerve, flat palpation would be inappropriate. If I'm using a muscle fold, then I'm drawing that muscle upwards towards myself, so it's further away from any structures within that area. So I'm going to needle onto the lateral portion of the gluteus maximus, and we would choose a needle which is appropriate to your intention and to your subject's body mass. So it may be that you need a 30 or a 40 mil needle. And remember, we can use both deep and superficial needling. So if this is the muscle level, superficial needling goes down just to touch the muscle, whereas a deep needle would go down to needle into the center of the muscle belly itself. So if we're using a superficial technique, I'm withdrawing my needle and palpating the area, again trying to reproduce his pain. I'm going to use flat palpation, so I've got an area of skin between my fingers, and then I press the needle in, I'm controlling that area, and then I'm searching out the tissue changes in that area. So I'm looking for a gripping sensation onto the needle, a slight stiffness as the needle goes into the muscle, and I'm looking for him to feel the reproduction of his symptoms. As I withdraw the needle, I release to start with, hold the skin down as the needle comes out, and then I'm disposing of the needle into the sharp spin again. So that's our gluteus maximus on the posterior portion, our gluteus medius on the lateral portion, and then beneath it we have our gluteus minimus. As we're coming further down, we can move on to the hamstring muscles, and we've got a choice of different techniques that we can use and a choice of different locations. I want to draw the muscle up and draw the muscle away from the underlying structures. Now we know that we have the sciatic nerve coming through here, so it's exiting the buttock midway between the trochanter and the ischial tuberosity, so it's coming down here, and then it's going to split into its popliteal components as it comes into the lower third of the thigh, and at this point the muscles and the neurovascular bundle in general will become more superficial. So for safety, I'm going to draw the muscle away from the bone. But obviously that's quite stressful on my hand. This is a very large, powerful muscle, and if I have to physically hold that muscle up, that can be stressful on my finger joint. So to make gravity work for me, I'm going to choose the Faber position. So if you could just spin yourself onto your back, please. And then we're going to have him into this position. If you can just shuffle slightly to this edge of the couch, and then your leg's going to come up into this position. So now I need to make sure that I'm on the hamstrings and I'm not on the adductors. So don't allow me to straighten your leg. So I can feel that resistance as I'm on the hamstring here. If you lift your knee upwards, then I can feel the adductors coming around here. So once I'm on my hamstrings here, as he lifts his knee up, I don't want to feel that muscle tighten substantially. As he presses that heel into the couch and stops me from straightening his leg, I want to feel the hamstring. Okay, so I know I'm onto the right position. I'm going to choose my needle, and then I can apply some hand sanitizing gel to my hands and to the area that we're going to needle. Okay, so once I take the needle out and I hold the needle in the position of insertion, I can then support his leg as it comes down. Now obviously if I was doing a prolonged manual therapy technique, then to use my own knee to support the patient wouldn't be appropriate. But as dry needling is only going to take a couple of minutes, one of the advantages in sport particularly is we don't necessarily need to do a lot of preparation to support the body. Okay, so I'm coming round onto the hamstring here, and I'm drawing that muscle away from the structures underneath. So I'm drawing them away down to the couch and away from the bone. And then I know that my thumb is more or less on the center of the thigh, so I'm going to avoid putting the needle in this direction above my thumb, so it always stays below the thumb. I insert the needle rapidly, and the initial resistance that I feel is going to be skin and subcutaneous tissue, and then I want to feel a drum-like resistance, which is firm muscle. Obviously that will vary depending on your subject. On an athlete, it's going to feel drum-like, and I'm gently going to press into that area. So I'm doing a pistoning stimulation where the needle is going up and down, and as that happens, the muscle starts to give way. If I want to increase the stimulation, then I can use a winding technique which will wind the fascial layers around the area of around the needle itself, and then as I withdraw that needle, I pull it towards the surface, but before it breaks free of the surface, I'm going to use my tube to press that skin down and withdraw the needle. Okay, inspect the area. If there are any spots of blood, then we're going to dab those with a sterile cotton wool ball, which I've prepared. So I just press that onto that area. So again, you can see the advantage of the technique in that it's quite rapid. If you think about the position that I chose, I've got stress on my wrist and I'm supporting him on my thigh, which is not very secure if I was doing a prolonged technique. But as the technique only takes some minutes, we can use these positions quite comfortably. So that's our hamstring. We can use the same position, our same favourite position, for our calf. So we come down onto our gastrocnemius muscle. We're below the knee using a very similar technique. So we have a large gastrocnemius here, and we're going to go into the belly itself. Now, we only need to go in, even if we're using the deepest technique, we would only need to go into the center of a muscle belly. If we go further than the center, then obviously we could have approached from the other side. And with our gastrocnemius, as we have two bellies, the depth itself is going to be about 1/4 of the total width of the muscle. So because the neurovascular bundle is coming down close to the bone, I'm going to draw the bulky muscle belly away from the bone itself. All right, so we're going to prepare our needle again. And I need to make sure that I'm in the right place. So I know I've got my gastrocnemius, I have my tibialis posterior, and then further down I have my soleus. So I need to make sure that I'm on the gastrocnemius belly, which we can see here anyway because it's well developed in this subject, but we'll just check. So if you point your foot down against my resistance, that's it. So I need to feel that muscle tightening under my hand. I palpate in that area to see if I can reproduce his symptoms. So I'm reproducing his familiar symptoms. I've supported his leg, withdrawing the needle, holding the needle horizontally, remember, so that it doesn't fall from the tube. Locate the area, and I know that my neurovascular bundle is beneath my thumb, so I'm going to make sure that I'm superficial to that area, so I'm always staying on this side of my thumb. So I place the needle onto the spot, tap rapidly to break the skin, and then I'm going to press into that area. Now I've got a number of different stimulations that I can use here, but because of the size of this muscle, I'm going to choose a fanning technique where I'm placing the needle in, withdrawing it slightly but not breaking free of the surface, and then I'm going to angle. So I can cover about 1 centimetre of the width of that area, so I can locate the tight points in that muscle. Once I feel that, I would expect a crescendo of symptoms. So the symptoms start to slowly build up and then they start to subside. And we're looking at a total of perhaps 2 minutes before that happens. And remember, the symptoms themselves are through the discharge of spontaneous electrical activity. So I'm literally trying to use the metal needle to short out some of that spontaneous electrical activity, which is one of the forms of that the trigger point presents itself with. Okay, so withdraw the needle slightly, release my muscle fold, hold the skin down, take the needle out, inspect the area just to make sure that we have no spots of blood. So once we've withdrawn the needle, we would then need to give the patient some home care. So he needs to be able to lengthen that muscle. So typically I would just get them to straighten the leg and draw the foot upwards, and they can use a towel wrapped around their foot. If they're familiar with calf stretches, then we can give them those. It needs to be a slow, relaxing stretch, so I would encourage them to not hold their breath. So I normally say to them, we'll not hold the stretch for between 3 and 5 breaths. That way I know they're not holding their breath, and it just encourages them to relax a little bit. We may find that after the needle has come out, obviously we've left a tiny wound within the muscle, and that is one of the the reasons that dry needling facilitates healing because of the wound healing itself, but that can be a little bit sore, so they may want to just use a little bit of superficial warmth, just a hot towel or a hot warm water bottle, something like this, just to ease some of the tension. When we're coming on to our soleus, the technique is the same as the gastrocnemius, but now we're localizing our area further down. So the gastrocnemius belly is coming round here. Our soleus is just coming beneath. So we can be more superficial than the tibialis posterior. So we're just coming into this thickened muscle here, and we can isolate that. So if you now just press down, so I want to feel something tightening under my fingers here, which is different than the gastrocnemius. If you straighten your leg and press down, so here I can feel the gastrocnemius with the leg straight. As I'm coming down here, as we bend the knee to take the force away from the gastrocnemius, I can feel something tightening under my fingers, which confirms I'm on to the soleus. So we've got a variety of different muscles that we've used into the lower limb. Finish now with the quadriceps muscles, and we've got different muscles that we can use. One of the most common is the rectus femoris. It's a biarticular muscle, a two-joint muscle, so it's commonly sprained. And in order to needle that, we know that the neurovascular bundle is actually lying beneath the femur. So the neurovascular bundle is coming through the femoral triangle, and then it's moving medially, and it wraps around behind the femur. So we can aim for the center of this muscle quite freely, because we've got no vascular structures there, or significant vascular structures there to concern ourselves with. As we come to the lower portion of the quadriceps, if we're moving on to the vastus medialis, again we can needle this, but we have the great saphenous vein coming down and wrapping beneath this muscle. So if it's apparent on your subject, then don't deliberately needle through it. So let's just have a look at the rectus itself. So we're going to isolate the muscle. Now on this particular subject, he's got quite good muscle tone, so just lying in that position, that muscle is isolated. It has become drum-like, and so it's easier to needle. But where you have a subject who has quite poor tone, you might want to just flex the knee to place the muscle slightly on stretch, so that when you're needling it, the muscle has come closer to the surface and it's firmer to deal with. All right, so we're going to clean the skin, and we're using a hand sanitizing gel here onto the skin and onto our own hands. In the sports situation, you would make sure that the skin had been cleaned beforehand. So if he'd just come off the rugby pitch and he's covered in mud, he's going to have a shower before we put the needle in, and we're establishing our clean field and making sure that we can see the skin around the area that we're going to needle. So it would be no good if you've got somebody with a pair of trousers just drawing the trousers up. You can't see the area above or below, so you don't know if he has an open wound. So we need to see a good sort of 6 inches around that area. Okay, so I've got a choice here. I can use a flat palpation to press that muscle down to the bone, or I can use a muscle fold, and both are appropriate, but it would depend very much on your subject. So I'm going to choose a muscle fold. I've lifted the muscle up, placing the needle onto the skin and just tapping, and then I'm stimulating that area. Now the muscle tone here is quite high, so I'm just going to pause for a while to let the subject get used to that needle, because obviously putting the needle into a very firm muscle can be a little bit more painful. And so we just gradually work that needle in, encouraging it to go in rather than just forcing. I'm looking at just working into the muscle fibers. So this technique would be contraindicated where the effects of the dry needling would be inappropriate. So we know that one of the effects of dry needling is to increase the amount of platelet-derived growth factor because we're deliberately injuring the area. We know that we are increasing the degree of blood flow to the area, so we're getting nitric oxide release. Now, if he had a myositis ossificans traumatica, so if he'd had a dead leg on the front of the thigh, which releases osteoblasts and osteoclasts into the area, unless I've got 90 degrees flexion, manual therapy in general would be contraindicated, but even so, I wouldn't deliberately needle into that area because the area has, one of the reasons that the myositis is occurring is because of the trauma to the muscle. So if I create more trauma to the muscle, I can increase or potentially exacerbate the myositis. So it would be contraindicated in myositis. Where we have an active bruise, so the bruise itself is still forming, we wouldn't want to needle into that area because again we already have too much blood, so we don't want to increase that. But where we have a bruise which is resolving, then we can needle around the bruise onto the fresh skin. So we wouldn't needle into the bruise, but by needling into the fresh skin, we're drawing the blood into that area. So contraindicated if we are going to find that the techniques that we achieve with our dry needling are inappropriate to the stage of healing of that particular condition.